we're not going to risk it because nobody's living. Like, no patient lived. The first 5 months that we had our COVID ICU.
No one survived?
We had 100% mortality.
Oh my God. Okay. Hi everyone, my name is Dhruv and welcome back to the third episode of Dhruvs Trailblazers. Tonight on the podcast, I have Andrew Shefford, who is a registered nurse in Canada and the patient care lead at SILS 4 Belleville General Hospital. He is going to take you through a range of emotions through his experiences as a nurse. If you are a nursing student or a nurse, this podcast is for you. Make sure you watch the whole podcast and do not forget to subscribe and leave a comment. Thank you. Thank you so much, Andrew, for joining me tonight.
My pleasure, Dhruv.
Thank you. Let's start with your journey. How did you get into nursing and your journey to become a registered nurse?
Oh, man, that's a pretty loaded question. I didn't know what I wanted to be my whole life. I did know that I wanted to work with people. I didn't know at what capacity, what that would be. Initially, my parents would always kind of funnel things when I was a kid. They would buy me like model skeletons or books on the human body, things like that. I always wanted to be a bone doctor is what I said. I knew a lot of the main bones when I was younger, but that surely fizzled out with the introduction of Pokemon in the mid 90s. So then I was just a kid growing up. But I think where things kind of changed, where I think wanted to be, in high school, you get all those competencies. I was never really directed where to go towards nursing. All of my jobs, I guess I'll start with where I've worked.
Absolutely.
Yeah. My first job was at 14, working at a local restaurant.
Was it in Belleville?
It was in Belleville.
Oh, which one is it, if you don't mind?
I don't want to throw them under the bus because
right.
they hired me not legally.
Oh, okay, all right.
So I'm not gonna. I love the guys that own the place,
Sure.
But when I turned 15, then they hired me on,
okay.
and then I was a formal worker there. But every summer job that I've ever had. Like when I was in school, like during high school, I'd be working at that restaurant. And then during the summer, I'd do a full-time job. And the easiest full-time job I could ever find was just being a camp counselor.
Oh, wow.
Like I loved being the loud one, the loud outgoing one, working with kids, working with people. That was kind of where I shined. I was at the YMCA camp for disabled children called Camp Ability. I did that for 3 summers. I did 2 in a row, and then I did it again closer to the end of my high school, like around grade 12. And then in between those other summers, I was at another camp called Wesley Acres, and that's it's a Christian Free Methodist camp up down in the county on Westlake. And I was a camp counselor for that for 3 other summers. So for like first 6 summers of my teenage life, I was pretty well just camp counseling the whole time because I loved working with people. I loved the interaction. I loved the excitement. Even going into university, I kind of tailgated into doing some bartending on weekends. Then one summer I ended up wanting to trying something completely different. I was like, maybe I'll just work trades. So I did one summer at Belleville Volkswagen here in town as just like a general shop boy.
Right.
I could use a different word that they would like to use, but I won't say it.
All right.
It's I don't know how age appropriate this podcast is.
Feel free.
Yeah, I was a shop slut. Let's be real. Let's be real about it. Like they weren't. Let's not beat around the bush here.
Sure.
So they did teach me how to. So I basically like cleaned up the shop, and they did eventually end up teaching me how to change brake pads, rotors, doing like wheel maintenance, oil changes, just the basic stuff. And I think I got the job because my dad was actually the master mechanic.
Oh my God.
helps to know someone. Whatever spot you're going to, it really helps to know where
Fair enough.
people in the industry. And that was the last summer I ever worked in an auto shop. I will say that. It was a little grueling. And then I tried the manual labor. I did this other job where I did landscaping. It was 100% commission landscaping. So you don't...
Was that in Belleville too?
This was in Hamilton.
Oh, okay.
Yeah. So it was my first... those other jobs... I was like between Belleville, Peterborough, St. Catharines, Hamilton. Those were kind of like where all of my life has been growing up. And when I was in Hamilton working, I was living in St. Catharines, and it was like... it was like this aeration. You know what an aerator is?
I guess.
It's like this big lawnmower looking machine, and it pokes holes in your lawn.
Oh, okay.
And me, with no competitive bone in my body, had to try and get people to convince them that aerating your lawn is the best thing that you can do for your lawn. Trust me. It's about the thatch that's in the grass. Anyways,
I have no doubt that you were able to convince them.
It was that's very generous. I wasn't the best at it, and I hated it. I remember one time, and it was grueling work too. Like it was, I'd have to wake up before the crack of dawn in the summer, which is like 5:30 in the morning, go to my bus stop, and then the company would pick me up in St. Catharines, drive me to Hamilton, which is an hour away-ish, and then they would give me my mower, drop me off in a subdivision with a map, and they say, this is your work for the day, we'll pick you up at dusk. So you're pushing this like 150, 200-pound machine from door to door to door to door, trying to convince people, like, hey, I'm a nursing student, and and this was when I was in nursing
so you were in nursing school at this time.
I was in nursing school then, but like it's all encompassing and for the whole story.
I see.
Because it's I'll circle around back to it, but and then even still, it was just like the grueling work, and it was the hard work. But my whole life, I was always like just working hard. Like just if I wasn't in school full time, I was always working full time. That's always been my life.
Do you think that kind of adds up to your work hours as a nurse now, like that work ethic that you had?
I think that work ethic was really helpful when I was in nursing school.
I see.
And I'll touch on that. I'm going to write this down.
Sure.
Work ethic. I'm writing this down, everyone. There we go. So I don't forget, because I forget everything. People that know me know that I forget things all the time. Sorry, Stephanie. Shout out to my clerk. Where nursing kind of came into play was when I graduated university, I fell in love with chemistry in high school. I had the best chemistry teachers in high school, and I wanted to do something with science. I didn't know at what capacity, so I got accepted to Trent University initially.
So you were in Trent?
Mm-hmm. For degree for oh my gosh, it was a double major in chemistry and math, and I didn't add the mathematics until my second year. So first year was just chemistry major, and then second year I was like, I think I can handle a double major, and I dropped out third semester. And it wasn't for any reason, but it was just really hard. And but what I ended up doing was when I dropped out, that's when I was working a whole bunch of different jobs. I was kind of like a lost puppy living in Peterborough there. I did do rowing kind of as a fun thing, but some of the other work that I did in Peterborough, aside from painting. And
you paint as well?
Yeah, I did painting.
Cool.
Yeah, I painted the cottage of the owner of Tip Top Tailors, and I was on the paint crew that painted his private cottage. I'm not going to say where, but it was a very, very, very nice cottage. And but aside from that, I also did. I think what kind of transitioned me into wanting to work with people again is I kind of circled back to working with people. I got a job at community living in Peterborough,
Oh, I see.
which is, if you're not familiar with community living,
I am actually. I think they have a branch here in Belleville on Bridge Street.
they do.
Yes.
Yeah, and it's kind of, they had a branch in Peterborough where they kind of set you up with, as like a life skills coach was my title.
Oh, nice.
So what I would do is I would help these adult men with disabilities transition out of home for independent living.
So were you still in nursing school at this time?
I was not nursing.
Okay.
This is Andrew as a dropout.
Oh, okay.
So
Perfect.
this was, if we go timeline, okay, so 2007 was Trent, 2008 was Trent,
And then you dropped out.
and then I dropped out.
And then you went into community living
Yeah,
in Peterborough.
yes.
All right.
And so it was, 2008, 9, and 10. I was working in Peterborough.
I see.
At community living with these disabled adults. It was such a fun job. Like, we had, I would take these people to open up their very first bank account and teach them about, like, safety of remembering your PIN and not giving your PIN out to anyone.
Right.
And that got challenging because one of the kids that adults, I will say, had a really severe FASD, which is fetal alcohol syndrome.
Oh.
And he was his own independent adult now, and I had to teach him the importance of making sure that no one has access to your money. That's including your family. And so that was kind of, I really enjoyed kind of empowering those kinds of, like that populations, working with, Campability and Belleville at YMCA.
Right.
Here.
Since you mentioned fetal alcohol syndrome, and I'm pretty sure if audience who are not into the medical field want to know just a bit about what is it. So if you would like to put like a short light on it.
Sure. So fetal alcohol syndrome happens when a mother drinks during pregnancy. I'm not an exact expert on fetal alcohol syndrome, but what alcohol does to an adult brain, which I imagine would translate to a fetus when they're in utero, is with alcohol, it puts pressure on our brain.
Right.
And which makes us loopy, makes us forget things. And I imagine that would be catastrophically exponential to like the baby growing.
For sure.
So they have like neuro deficits. They have like a type of look about them that kind of trends with other people with fetal alcohol syndrome.
Right.
But people can live very normal lives with fetal alcohol. It's a sliding scale, kind of like Down syndrome
I
or
see.
autism.
Right.
There's kind of like a spectrum of where like you can live a very normal life or you could be completely debilitated with it.
Fair enough. No, that definitely helps. And thank you. Thank you.
No worries.
Yeah.
Yeah. So, he was great to work with. I helped him get a job at a local hotel to
Wow.
and I was just watching him vacuum all day. It was a lot of fun. And so I really enjoyed working with people. And I was like, well, what's the next step? Like, maybe I can be a teacher.
Right.
So what I ended up doing was I need to have a clean slate when I reapply to university because my marks got tarnished and when I dropped out, and I need to do something different. So I moved back home to Belleville and I went to Loyalist College and I did their pre-health program in 2010.
I see.
With the intention of going into teaching, but there was a lot of nursing influence there. And then I was like, my mom was a nurse, my brother's a physiotherapist, and like I've always liked working with people. And one of the things that I didn't know at the time is that nursing is probably the best job to have if you love providing people dignity and
Wow.
and like honoring people in whatever state that they're at. That plus just like learning about people and seeing humanity when they're at their lowest self. You really kind of see the strength of people when they're kind of at their lowest low and see like the gusto of what people are made of.
I think that's a very beautiful way to describe it. For sure.
Thanks. Yeah.
Wow.
But-
So you were influenced into nursing. You went in to be a teacher at Loyalist.
Yeah.
So and then you were influenced into nursing. How did that happen, the transition? Was it because of the family or students that you saw at school, or?
I don't know. I think it was just, it could have been the influences on just my peers around me, because I think like 80% of the pre-health program, I think it's still current today.
Yes.
People go into the pre-health program to segue into a program at Loyalist. Because at the time when people were applying to the nursing program, when I was looking at applying to Loyalist, like the bachelor, the applicants that were coming out of high school, they say on paper, you know, like, oh, you need an 80% or 70% minimum, 80% average in sciences to even like apply to this. And then so I'm like, oh, I had those marks in high school. Like I could probably use my high school marks. But the reality is, the people that were applying, getting in at that time, their average was like 95, 96.
Wow.
Yeah, and I'm like, I don't have those marks. I'm not that smart, Dhruv. It's all a ruse.
I doubt that, Andrew.
But so the one of the ways to go about it was it's an easier segue, and they have a path kind of laid out for people that show interest in nursing that are graduates from the pre-health program.
Right.
I don't want to say they're considered over other external applicants. I believe, I don't know how they actually choose, but it seemed like that was how it was when I got in. So every time I would pass another year of school, I'd always be amazed, like, oh my gosh, I'm still in this program and I can't believe it.
Wow.
But yeah, and then I think what kind of kept me with it was I just really wanted to continue to work with people, because, you know, any job can be very routine and very mundane, day to day, Monday to Friday, check emails, sit at a desk, whatever. But the thing that keeps our job interesting, and your future job, Drew, is we get to work with people, and everyone's different. And so every day you're always going to be experiencing like different things.
That is so true, because I went to the placement today at VGH and I saw that my patient is not there anymore. And I was going to say my final goodbyes to the patient, because I knew that my patient is leaving the hospital and is moving to another place. And when I went there, they told me, oh, the patient left at 11. I was like, oh my God. And I could not say her goodbye. And I know that she was going through a lot, and I could have given more emotional support on my last placement. But I thought I'd do it today, and the patient was not there. So I totally understand and agree with what you just said. Yep. And I wanted to ask, so when you were a student, which placement was your best placement?
Two stick out. One placement that I had was the first one, which I think was my second favorite, was when I got placed with public health. It was just out of the class where we're learning about primary care. And we had a very strong political advocate in the nursing program. That was one of our teachers, who doesn't work there anymore. Elizabeth is her name. Oh. And she'd always light the fire under people's butt to get like politically active, and which was great. Like, just, and this is a side example. Right. Like one time I was upset at Belleville at the hospital, and my teacher was like, why are you, like, Elizabeth was like, why are you so upset, like, at the hospital? What's going on? I was like, well, can you just believe that they ran out of warm blankets? The hospital ran out of warm blankets. How are we going to get warm blankets to our cold patients at night, Elizabeth? And she's just like, do you think that's a hospital problem? I'm like, well, yeah, I think it's a hospital problem. And then she's like, or do you think it's a government problem?
Oh, okay. I see how politics got involved in there.
It all circles back to money, right? Like, if we can't, it's like, there's a reason why and every time a patient would always, I kind of changed how I interact with some of my patients. They're like, I just can't believe the food around here. That's always their number one. I'm sure you've heard it quite a bit in your placements. I have,
yes.
I can't believe the food in this hospital. Can you believe it? It's like, actually, I can. And if you don't like it, here's the letter to your local member of provincial parliament. Anyways, that's a side note. So we were learning about, I was in her class learning about primary care.
What year were you in? Do you remember?
This was in my 4th semester.
Oh, I see.
Yeah.
Okay.
So it was in February, like January, February. Yeah.
So it was
in
second year. Yep.
Yeah, my 4th semester.
Oh.
And because it was like that, and then right after that was my maternity placement, which was my favorite placement. I'll tell you why in a bit.
Someone just asked me today at my placement, when am I going to go into the maternity placement? I have no idea, but I'm pretty excited for that too.
It's an incredible experience. It's amazing. I'll talk about it after I talk about public health.
Absolutely.
That's okay. So, I was very interested in going to public health because it was like, hey, every dollar, the teacher, Elizabeth, was like, every dollar spent in public health saves like $10 on the patient, like in the future kind of thing. Wow. So it's worth investing in. And I'm like, yeah, now I want to work in public health. So I got the placement in public health, and it was a lot of fun. We'd go around to high schools and do like vaccine clinics in high schools. So out of in that placement, I did over like 300 IM injections, like vaccinations and stuff.
Wow.
And really controversially, it was the first year where the government was putting out the funded, I think it's called Gardasil, or the HPV vaccine.
Okay.
For that, we just started doing preventative vaccinations for teenage women. The government just made it public, and oh my goodness, it was crazy the kinds of things that you would hear, like because people could come in to they have to have your your consent for it, and this was also controversial. Teenagers could consent themselves to get this vaccine.
I see.
And depending on what age they were. And some parents would be barging into the hospital and just be like, or into the high school, and would be like, my daughter's not getting this vaccine. She is not having sex. And we're like, it's got nothing to do with that.
Right.
It prevents like cervical cancer, which the number one cause that causes cervical cancer, and like. It was insane, and naturally that got me fired up, and I really enjoyed that placement, and a lot of the health teaching too. I was in with a lot of like sexual health clinics with high schoolers as well, which was a lot of fun, with a lot of the boys in like high school classes. I got to be a part of just kind of be like a fly on the wall with some tough conversations with some students that were working through the John Howard Society.
Oh, John Howard Society?
John Howard Society?
I think that's...
John Howard Society.
John Howard Society, yes.
Yeah, and if you're not familiar with that, it's a great organization too. But I think that was like a really, really good placement for that. But then my favorite placement was maternity. When I got into nursing, I was like, I knew that I was going to be a labor and delivery nurse. That was my bread and butter, my whole nursing career. Like through school, I was like, I want to be an L&D nurse. I want to be a part of let's like the hype crew. Right. It's like raining in the new life into the world. You're like, you got this, like just get real hype with the mom.
Absolutely.
And stuff. And my placement was very much that. I had a really cool labor experience, like with my nurse that I had. I can't remember her name. She was a Spitfire, and it was up on Quinny 7 up in a BGH. I wish I remembered her name. I'd give her a huge shout out.
I was going to say shout out to the nurse who was there, if she's watching.
Yeah, and it was amazing. It was exactly how I imagined it would be, because we learned APGAR and we learned like baby assessments, and we learned about all these other things in class, and I was just eating it all, and everything that we're learning in class I'm seeing right here in this moment, and I was like, this is where I want to be. And what else was rather special too is I was a part of, again, some really hard conversations, because when sometimes life comes into the world and it's really nice, but other times you can take a turn and then you're experienced with completely polar opposite things.
Absolutely.
Like, is your husband abusing you?
Right.
Kind of things. And we had...
So when you say, for example, that kind of situation arises that, hey, is your husband abusing you? What kind of signs do you look for as a nurse that, and you know that when you ask that question?
I didn't know what the signs were. And
okay.
I was just kind of observing, and some of the signs, the takeaway, because again, I didn't know what was going on. But when the husband left the room, my nurse took me aside and was like, do you realize what's going on? I'm like, no. Like, I noticed some weird energy that's going on in there, but like, I don't really know what's going on. The over talking, like every time, and you'll see this in your nursing practice when you're talking to a patient, but then family will jet in, or
right.
You're trying to talk to a nurse and her husband's like speaking for her on her behalf. What I learned is that's a big red flag. And what was happening is every time we would ask this mother a question, the husband would answer, and the body language which was being communicated very clearly was very suggestive of
abuse.
That abuse was happening in the home. So when we kindly redirected the husband to go get a coffee for everyone, he was like, yeah, sure, I'll be right back. And the second he stepped out, we brought the charge nurse, the bedside nurse, and myself, and the social worker. And we kind of offered, like, do you need support in the home? Are you safe at home? And she said no.
Oh.
So we had to call children. What's it? I was in the States for like 6 years.
So this is
Children's Aid Society?
CAS.
CAS. Okay.
Yes.
Okay.
Yes.
Yeah.
Oh, so this was in States.
No, this was here in
Canada. This was here in Canada.
Belleville.
Okay, all right.
Yeah.
Oh, wow. Okay.
Yeah, I couldn't remember if it was CAS or CPS.
It is CES, I guess. Oh, that's for children, though. That is the one you're talking about, right?
Society.
Yes, CS.
In the States, it's child
protection
protected services, right, or whatever. But,
so I just wanted to ask, because I think I just had a class on abuse last week. So when the patient says that, yes, there is, the patient consents to abuse, that yes, abuse is going on at home, are we allowed to report it?
As a student?
As a nurse?
I think it's the law when we suspect that that children are being abused. I think legally we have to.
Oh, for children, yes.
Yeah.
And if it's an adult?
If it's an adult, I believe we need consent from the abused.
Okay, all right. I see, the victim.
Yeah, the victim has to give consent.
That yes, we can
Don't
report
quote
it.
me on that.
No.
That's just how I've learned my practice.
Right.
I've never worked directly with that population, so I don't know exactly, but that's how I understand the law.
So how did things go then when she said that yes, there's abuse going on?
That was my last day of placement.
Oh.
Yeah, it was a very but it left like a deep mark on my heart, because it was the day after I saw the birth, and then we're like, okay, we saw the birth, let's go see what the aftercare is like, and that was the aftercare for this particular family that I was paired with for the day. And it was just like the high was high and the low was very low. And I think that's kind of what you hear commonly when people go into labor and delivery, is that, it's not always rainbows and fun and joyous.
Right.
You got to go through some of the most traumatic experiences that some women have when they go in and they have birth. Sometimes they'll have a stillborn or a preterm pregnancy, or they'll have to have like some, like, there's genetic things and they'll abort the baby, or there's a miscarriage, and there's a lot of traumatic things that can happen, which is terrible that can happen. One of the professors that I had at Brock University,
So at that time you had to go to Brock for your last 2 years or something like that?
Yeah.
Oh, okay.
So I did the 2 years Loyalist, 2 years Brock.
2 years of Brock, okay.
And one of the professors that I had at Brock wrote her PhD on what it means to have a miscarriage. And she interviewed 50 women with her PhD dissertation. And it was just a powerful thing. And she painted a picture of how she felt, what people were going through, kind of thing. It was really moving.
Wow.
Joyce Engel was her name, the professor's name.
Right.
But yeah, and then I think after that placement, I was like, I am gonna be a labor and delivery nurse. And so for the rest of school, everything was just kind of like a blur, for various reasons, mainly because you're in school.
Right.
And yeah, and then when I was doing my consolidation class,
Yes.
I got trapped, Dhruv. The trap was, you need to go to medicine to own your skills before you can spread your wings and fly to anywhere else.
Oh, okay. Do you want to elaborate?
Of course.
Thank you.
So it's very common to hear, like, oh, you're a nursing student. Make sure that when you graduate, you start on a nursing floor. Or sorry, on a medicine floor.
Okay.
Because there's a lot of things that can happen on a medicine floor. And it's a really good spot to learn your skills and to learn your practice. And then from there, you can branch out and do other things from there. It's not bad advice. My advice would be, if you have your mind set on something and you want to do that right out of school, just do it.
I see.
Like if your dream is to be an ICU nurse, just apply straight to the ICU right out of university. They will teach you. It is working in critical care for 8 years that I have before doing this patient care lead.
Right.
Some of the best hires that we had were new grads.
Oh, wow.
They're malleable. The iron is hot with them, metaphorically, meaning like they're just really easy to mold into the position that you're training them for.
It's the fire. They're just graduated and
they're just
want to get hands on.
And they're sponges. They're like, I can now do this, and I now earned my stripes, and I'm making money doing it too, which also helps too.
Right. So the trap was
I went to medicine.
Oh, I see.
And that's where I've been my whole career. And I still have a passion for labor and delivery.
So you did not get to work in labor and delivery yet?
Never.
Oh my God. Okay.
And now I'm 36. I'm a 36-year-old man with a really dirty mustache. And like,
it's not dirty.
Yeah, thank you, Drew. I really appreciate that. You hear that, Kelsey? That's my wife. Yeah. Somebody liked my mustache. Thank you. I think I got distracted by my mustache. What was I saying, Drew?
Oh, you were telling us that you got trapped into working on medicine, and then you've been working.
Yeah. So now I've been, I feel like, everyone, I've talked to some people, they're like, oh, you can just do whatever you want, like go back. But I'm at the stage in my career where like the imagery of, and this is my own thing.
Yeah.
It doesn't mean it's truth. This is just my own belief and how I feel about myself. It's me. It's all me. But I feel that it's weird if I was to go into labor and delivery at the stage that I am at in my career.
Oh, you think so?
I think so. I think it would be like and I think it's just the imagery of it. Like not to say that, there's a lot of great men in labor and delivery. There's a lot of great men that continue to work in labor and delivery.
Right. But you don't feel that now is the right time to make a change? Is it something like that?
Yeah, for me personally, I feel like that would be, I don't know. There's other things that I should be focusing my attention on.
So would you consider labor and delivery if right out of school you went into labor and delivery?
Yeah, if I was to do it all over again, I would have went straight to labor and delivery
I see.
right out of high school, or right out of university.
Right.
Yeah. I think that would be. I think that would have been, and then I think that would have completely changed my life trajectory with everything. Obviously,
But do you think working in medicine also was not bad?
it was also an incredible experience. It's the only experience I have.
I see.
But it was invaluable for a lot of other reasons. Not to say that working in medicine is terrible. I ended up really love working in medicine. My last two placements, my consolidation placements in fourth year, was with Carson and Kim. Carson still actually works at Quinny Health.
Oh.
He's a patient care lead on Quinny 4. He was surgery.
Oh, wow.
So he was.
And now you're the patient care lead at Sales 4.
Or Sales 4. Oh, so did I say Sales 4?
No, he's at 24, you said,
yeah,
but you're
I
at Sales 4.
I know. We crossed paths. I'm like, Carson. He's like, Andrew, what are you doing here? Anyways, we had a good little catch up. But yeah, he was like my dad of nursing, if you will.
Wow.
But yeah, so I was in surgery with him, and then I did medicine with Kim. And I think the thing that made me fall in love with medicine, that made me okay with where I was, is that there's a lot of stuff you can do. There's a lot of stuff you can learn.
Do you want to give any examples?
Yeah, like
Sure.
In university, I was terrible at the endocrine system.
Okay.
Like every other nursing student is. Like, who knows about like the pathway of what is the pituitary gland, and how does it interact with your kidneys?
I feel attacked right now.
I know. I feel attacked. I barely know that too. But you get to, if you work in that area, you really get to learn those things.
Right.
And you get to learn subtleties of medicine that you don't get to see. From working in a medicine floor, I upgraded to a medical ICU. In medical, in the hospital that I worked at down in the States, that hospital was huge. It had 4 different ICUs. It had a medical ICU, it had a cardiovascular ICU, it had a surgical trauma ICU, and it had a neurological ICU.
So you said you worked in the States. So I'm guessing after you graduated from your nursing school, did you go straight to the States or?
As a new grad, yeah.
Oh, wow.
Yeah.
Wow.
Yeah. I was like, what in their right mind? Who would hire a Canadian new grad? Turns out they all want nurses down there too.
Perfect.
Yeah.
Well, that gives hope, I guess.
Yeah, it gives hope to anybody.
Yeah.
But stay in Canada because we need nurses here too.
Fair enough. Yes.
That's why I came back to Canada because I love Canada.
So how many? What was the duration of the time, or how long did you work in the States for?
6.5 years.
Wow. Oh,
Yep,
that's a long time.
Yeah, I was in medicine on like a medicine floor for 1.5 years. And then I transitioned to their medical ICU for 2 years. And then the world went to crap, Dhruv. The pandemic happened.
Oh, right. Tell us about that. How was that experience as a nurse?
I'm still unpacking the trauma that I experienced from working in the States because
During COVID.
During COVID, because in medicine, in medical ICU, you become the experts on sepsis, respiratory failure,
Right.
organ failure, liver failure, kidney failure. Usually like cardiovascular failure, cardiac
Right.
failure would be like, cardiac ICU. Trauma would be trauma ICU, that kind of stuff. But anything else, sepsis or organ failure or immunocompromisation, anything like that would be medicine. So those were the avenues that I'd be really good at. Naturally, when the pandemic came out, they're like, we need to create a COVID ICU. So it was crazy, Dhruv. It was the first COVID patient that was in an Arizona hospital was at our hospital because it's at the University of Arizona. And they're like, we're taking our first COVID patient. Do not talk to the media. Because if media found out, it would be all pandemonium, they said.
Oh, sure.
And they were handpicking nurses to work with them, to work with the patient.
What was the reaction of your fellow nurses when you all found out that, the first COVID patient in Arizona is right here?
Initially, we were like, they're exaggerating.
Oh, okay.
Yeah, like they're going way too over the top. Yes, it's infectious. Yes, we still don't know how deadly this virus is. It's probably going to be like SARS. SARS was terrifying.
Right.
People died in SARS.
Yes.
The curtain was still covered. We didn't know what was behind the curtain when the first patient came to our unit. When half of the medical ICU were COVID patients, rather I should say patients with COVID. You're welcome, Elizabeth.
So Elizabeth is, let's just let everyone know.
Elizabeth Edwards, she's probably the biggest influence on my nursing practice.
Oh, perfect. Okay.
Yeah, she's her, Julia Abelard, and Patricia Monroe. Those three were my anchors through nursing school. Yeah,
well, I'll make sure we send this podcast to them.
Yeah. Yes, they would. I'm sure they would love it.
We'll have to find them. So yes, you were talking about.
So the pandemic.
Yes.
Yeah. So when it came to a point where now we had to segregate these patients with COVID away from the rest of the general population, they were taking volunteers. So we have again 4 different ICUs. So it was you can work in the COVID ICU if you choose to do so. We're not forcing anyone to work in that environment.
Oh, I see.
All volunteer basis.
How many did volunteer?
Enough to run an 18-bed COVID ICU.
Oh, so you had okay, I see.
Yeah,
oh,
so
that's a lot too.
It's a lot.
Yes.
Yeah. And I volunteered.
Oh, you did?
Mm-hmm.
Wow.
Yeah.
Thank you. Salute.
Oh, well, yeah, it's whatever.
No, seriously.
Yeah, it was crazy.
Because it's like putting, like your own life
we didn't know.
out there. Yes.
I was trusting that I'm healthy and that I would rather me, who would likely have a better shot of surviving, which at the time, at least the patients that we were seeing in the ICU, COVID didn't discriminate who it killed. That's what we saw. I'll touch on that in a second, but sure. It was like we were getting volunteers, and that's when I ended up with my first patient care lead role.
Oh, wow. This is in Arizona.
I was the first patient care lead for Arizona's first
COVID unit.
ICU at the University of Arizona.
Wow, that is huge.
It was huge. I was shocked that they even considered me to take that role. So what that role entailed, so there were 2 patient care leads. It would be split between myself and another one of my colleagues, Keith, and we would have one other person float on a Sunday, so she would kind of just hold the fort over until we got back on Monday. And what I had to do in that role was to update our staff every day what the WHO was saying, what the CDC was saying on best practices on how to protect yourself from COVID. And I would take those recommendations, type it up, and update the PPE recommendations for the corporation that I worked for. So at the end of my shift, I'd send emails and phone calls to other clinical operations managers or whatever from other hospitals, and say, this was yesterday's recommendation, this is today's recommendation. Make sure
you were updating them every day.
I was updating them every day.
Wow.
Yeah, from 3 different other huge hospitals in Arizona.
So when the first patient came, and then when you went to assess the patient and do an assessment on the patient, at that time, what was the PPE?
It was full blown at that time because we had the resources.
Oh, okay.
It got really scary. We had first they're saying we need to wear the full hazmat suit. So we were doing that.
Oh, I see.
And then a recommendation came out, said it's actually droplet. So we didn't have to do airborne precautions. We could do droplet precautions now.
Right.
So we were just wearing just a regular mask and regular gowns for droplet precautions, like influenza precautions. Regular hand hygiene. But people weren't doing that because we're not going to risk it because nobody's living. Like, no patient lived. The first 5 months that we had our COVID ICU,
no one survived.
We had a 100% mortality rate.
Oh my God! Okay.
And that was the same for everywhere.
True.
Nobody knew how to treat it.
And what about the nurses at that time?
We were terrified. Like when we are, because like when they're like, yeah, when they went from a hazmat suit to droplet precautions, I had nurses screaming at me saying, I am not going into this patient room wearing a regular mask.
Right.
This patient is younger than me and they're dying.
Yes.
And they're like, I'm going to wear whatever I need to wear to keep myself safe.
So,
and I'm like, do what you need to do to keep yourself safe.
Absolutely.
These are the recommendations, but I'd always preach, do what you need to do to make yourself feel safe.
Right.
And
so did any of the nurses back out at any point? Looking, yeah,
lots.
I'm pretty sure.
Yeah, it got bad. It was really bad. When the deaths were just like, it was very common to see 9 to 10 people die on any given day on our floor during the worst of it. In our small ICU, we actually had to move it to a bigger ICU, to our 24-bed ICU. And we were the ECMO specialty unit too for COVID. So people from out of state would refer their young patients that have a chance to our floor so they could get on ECMO. ECMO is extracorporeal membrane oxygenator. And what this machine does, for those of you who are listening, they put like a garden hose through your neck. It's like the size of a garden hose. It's a 23 French, which is massive.
Yes.
And that line goes through your jugular, through your heart. It goes through your atrium. So it's pulling blood from your inferior vena cava and your superior vena cava, pulling your entire blood supply out of your body, oxygenating it, and putting it back into your body.
It's like dialysis, but not for your lungs. Yes,
it's dialysis, where dialysis cleans your blood. ECMO just oxygenates your blood.
Wow!
It takes out the carbon dioxide and it puts in the oxygen, and then it shoots it into because your lungs ain't working. Some of these people, like you and me, our tidal volume would be anywhere from like 400 to, our regular tidal volume would be like 400 to 600 mils of just like normal breathing.
Right.
Our COVID patients, 20 milliliters of air could get into their lungs. Their lungs were flooded. They were breaking down. And they, what was crazy was like, when we started seeing people live during that was when we started anticoagulating people.
Okay.
Because I was in America, people didn't believe that COVID was killing people. People weren't getting vaccinated.
Right.
People were just dying, and they're like, I can't believe it must be something else. COVID doesn't exist. And I'm still amazed at how many people out there don't actually know what Delta wave was doing that was making the people die. Yeah, the virus doesn't kill you. It's what the virus does to your body that the virus leaves your body in a state, and that state kills you.
Right. I think that's the perfect way to describe it.
It's like so what the virus would, and a lot of people would be like, oh, if you're diabetic, you're predisposed to getting worse. It was high cholesterol. We found that it traveled down. There's a study that came out of South America, and they found that the COVID virus traveled through the ACE pathway, the acetylcholinesterase pathway,
Right.
which is linked to cholesterol.
So what do you say? I mean, if this is the right interpretation, obese people were at a higher chance of getting highly infected with this virus.
Increased chance of mortality.
Yes. And
Yeah.
yes. Oh,
But it could also be a person like you or me that just have, we go to the gym every day. I don't
Right.
go to the gym every day. But say I went to the gym every day and all I'm eating is steak, eggs, potatoes, butter, lard, high fat, high protein.
there's no balance there.
No
It's just-
balance.
yes.
That would be a determining factor, in my opinion,
Yes. I
of
think.
increased risk of mortality. Because when we found everybody that was dying had some kind of high levels of cholesterol. And a really common one and a really sad one was pregnant women.
Oh, yes.
We saw dozens of pregnant women die in our ICU, which was the worst thing I've ever experienced in my life. But yeah, it was kind of what made me move back to Canada actually was,
Oh, so did you move back right after COVID?
it was when they announced Omicron.
Oh, I see. Okay.
Yeah, we didn't know what Omicron was going to be like.
Do you want to put some light on it?
Yeah. So just to kind of share what made me really firm my decision moving back to Canada. Delta, Arizona, there's a 3-week period in January during Delta wave where Arizona was the global epicenter for infection rate and deaths in the world. It was the worst in the world. It was what New York was experiencing when they were hitting the news. Other parts of the world ended up experiencing that, but New York was just the first one. Other places had it just as bad, and Arizona was the epicenter for 2 to 3 weeks at that time. And we're talking like, I don't know, maybe like 90, 100 people died in like a month and a half period just in a 24-bed ICU. It's just
Just
rotating
circling.
people, beds, clean bed, get a new one, they die. Clean the bed, get a new one, they die.
How did that affect you as a person?
I'm still messed up. And I laugh about it because it's the only thing I can do.
Fair enough. Yes.
It's there's still to this day certain sounds that I'll hear in the hospital, and I'm very removed from that experience. I'm really removed from COVID anymore, from critical care anymore. But there are still some sounds that you hear, like what a Philips monitor sounds like a bedside Philips monitor sounds like when a patient's oxygenation is low. It makes a certain ring. And when you hear that, it triggers me. Not in a good way. Probably more of like I can feel myself. It's so weird. I can feel myself like coming alive. Like it's like I become more alert, and it's just like my senses just dial in and being like, what I'm like ready to do. Let's go to where that noise is.
It's like your sympathetic system just turns on.
It was insane because that's what all we'd hear every day. You'd go into a room, code one patient, they wouldn't make it, and you can't even mourn that patient that you're taking care of. You just step out. You're like, who's next? That one down there. Let's go over there. And it's the same noises. The boo, 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 boo.
Oh, damn.
Yeah, and it's like everybody. And yeah, so it's still, and I really probably should go to therapy for it, but I don't know. I don't know. And this is, again, me. I probably will never go to therapy for it. And my reason for it is I don't want to lessen my experience or or the memory of the people that I've taken care of.
I see.
Because it was very traumatic for me. very hard.
And that kind of builds you to what you are today. Is that what you're saying? And that would kind of lessen the experience.
Yeah.
You want to keep it all in.
I want to keep it. I want to feel it. Because if I was to work through it and heal that part of my heart, it would dishonor the people that I cared for. It's my own
No. That is
my
actually
own thing.
That's very beautiful. I mean, I don't know if the other listeners can relate to it, but I can definitely try to understand what you're saying. And wow, it's a beautiful way to describe it, that keeping it as an honor for the patients who did not make it.
Yeah.
Wow.
Yeah.
It's beautiful.
Thanks. Yeah. And then when, so if I'm resegmenting to when the Omicron was announced, because we hear everything through, we were always the first one to hear everything first. And they're like, Omicron announced, and we don't know what it's going to look like. And this is right when we got through the worst of Delta.
Right.
I went home.
Oh, so now you came back to Canada.
That was, that's when I started the preparation to go back to Canada.
Oh, I see.
Yeah. As I went home and I was like, Kelsey, it's my wife. Like,
oh, were you married at that time?
Mm-hmm.
Oh, we'll add that later. How did you meet your wife, if that's okay?
Yeah, that's fine.
All right,
yeah,
perfect.
We met on the internet. It was great.
All right.
But I went home to my wife and I'm like, I am not going to do another wave of this. We're going to move to Canada. And she's like, you got it. And she started getting all of her stuff ready to, she had to go through all the immigration and all the, because she's a nurse herself, she had to go through the equivalency, she had to go through all that stuff. So it took us like a year from the time we started the process to actually moving back. Yeah.
Oh, I see. Okay.
But until then, I still had to suffer through working in the COVID ICU.
Right. How does she like Canada?
She loves it.
She loves it. Oh, that's pretty nice.
Yeah. Belleville, she says that Belleville's the best thing since sliced bread.
Wow.
She loves how quiet it is. She loves how quirky it is. She reads the community press like every week.
Okay.
And she's like, and my favorite person's writing their opinion again this week. Because the first week that she was here, she read an opinion piece of this one guy who was writing about underwear.
Was it on Facebook?
Yeah, it was in the community press.
Oh, okay.
It was in the free paper that gets delivered to our house every week. They're like, I'm just gonna. She's like, I'm just gonna see what this is all about. And she's like, oh my God, you need to read this article. And yeah, she's hooked. Yeah,
you never know what you might find in those articles.
You never know. You never know.
That's so true.
No.
Wow. So then you moved to Canada in which year?
2021 was when November 21 was when I quit in Arizona. We moved in January of 22.
Oh, I see.
Yeah, and I started working at BGH in 22.
Also, BGH is your first
Canadian job.
Wow.
As a nurse, yeah.
And you love it here, I guess.
I do, yeah.
Yeah. Wow.
It's different. I mean, you can't. It's like comparing apples and oranges. It's like like an academic, private American hospital at a university versus Belleville, Ontario, where like the population of Belleville and Greater Belleville area is like a tenth the size of the city that I was working in, kind of thing. So it was like Belleville's a small, and Belleville's an old hospital too. It's like almost as old as Canada. It's got a crazy history, actually. The hospital. I
think that's true.
Yeah, they had a nursing school right there too. It's actually kind of fascinating. They got a lot of interesting.
Oh, really?
Yeah.
Wow,
yeah.
I never knew that.
But there's a lot of like old culture at Belleville General Hospital too, which I'm sure gets talked about in nursing school. What like nursing culture looks like.
Yes.
The culture in Arizona was very academic focused and best practice focused, and what we see a lot in older hospitals, not just Belleville, but you'll see a lot of that's not how we do things around here, kind of thing. And when sometimes it's kind of hard to introduce best practices when things don't need to be changed, presumably.
Right. Since you mentioned best practices, and you are on SILS4, that is CCC. Mm-hmm. And do you want to tell what it stands for?
Yeah. So I'm actually really proud to work on this little floor. It's an 18-bed unit, complex continuing care. When you hear that name, you're like, oh, so definitely it's a longer-term unit working with patients with complexities. It's actually a rehab unit. it's a specialized rehab unit, and we have it's like, in my opinion, probably the most important unit that the patients on our floor get to when it comes to their recovery. Because when we have a few different populations. We have one population where it's a stroke population, where patients that have a traumatic stroke, they survive their stroke, and now their body's turning back on. Their brain's turning back on.
Right.
Their body's turning back on. We need to start introducing slow stream therapy to you.
So that is when they are moved to your floor.
Correct.
Cells 4 CC, continuing critical care.
Complex continuum care.
Sorry, complex continuing care.
All good.
And then that is cells 3 when they initially get the stroke. They're at cells 3, right? They have a stroke.
Yeah. So the stroke process, they go to emergency department, and once they've done what they do there, they'll move them to either the ICU, depending on how bad they are, or the acute inpatient stroke unit, which is on cells 3.
Cells 3.
And then once they recover enough from their acute phase, then they're like, we can start introducing therapy. Then they come to CCC. And then once they get to a level, like a higher level of participation, like, you're doing so good, now we can send you back down to cells 3 to their rehab floor. Cells 3 is kind of separated to 2 units. They have the acute side, and then they have their rehab side.
Sounds like a bifurcation.
Yeah.
Oh, perfect.
Just like the bronchioles.
Yeah, that's what came to my mind when you were explaining that.
Yeah. The nursing station's the carina. You remember some of your classmates will remember what the carina is.
I hope so.
Yeah, I hope so too.
Yeah.
Anyways, so that's one population. Another population is, you broke a hip and you live by yourself at home and you can't take care of yourself.
Oh, okay.
You'll convalesce on our floor and wait for weight-bearing status to be given back to you by your orthopedic surgeon.
Oh, I see.
So once you get weight-bearing status back, then we can start introducing therapy, and then we can send you wherever you need to go.
Oh, okay.
And then the other one is generalized weakness. So people that just prolonged hospital stay, they're just been in a bed for months and months, and they are so deconditioned. But whatever is going on is resolved. They're medically stable, and now they can start participating in therapy. So we'll start introducing that.
The more independent they get, and then that's their way to leave the floor.
Yeah.
In a very respectful way.
Yeah. And then we have one more population, which is our chronics. We have 3 patients on the floor right now that are kind of like our long-term place. Hastings and Prince Edward County doesn't have a nursing facility that can safely house patients with tracheostomies. Require. They've had patients with trachs before. I'm not saying that they don't do it.
Right.
But if they require deep suctioning every day, which our patients do, or need to have supplemental humidification and oxygen while they sleep, which our patients do, then we're the only unit in Hastings and Prince Edward County that can do that.
Oh, so your unit is the only unit that does that.
The next closest is in Kingston, at Providence Care Hospital.
I feel so grateful right now that my placement is at your unit, because you said you're the only unit who does that, and
we're the only one. Yeah.
And I have the chance to learn the intratracheal suctioning, and then all the other things that I've learned so far. Thanks to you, and thanks to everyone on the floor. If they're listening I hope they do listen to this.
Yeah, it's recorded, right?
Yes.
I can listen back to this.
Oh, absolutely.
Awesome.
Yes.
Yeah.
Perfect. Oh, and then since we were talking about best practices, and let's talk about some of the practices that I have learned and that we have learned. I mean, when I say we, my classmates are included here on your floor. And first of all, thank you to everyone. Thank you, Andrew. Thank you to every other nurse and every other staff on the floor who is so welcoming with so much energy for us. So a big shout out and thank you to the whole floor.
CCC. That's my homies over there.
Yep, there we go. So, for example, endotracheal suctioning. If you talk about the best practice, the suctioning tube that we use, so should we use it only once when it goes through the trach, or I've heard that some people do it 3 times, use it 3 times, and then, but I believe the best practice is to use it once and then throw it off. What would you say?
I'm one and done.
One and done. Okay.
Yes, and this was based off a conversation that we had last year with our professional practice coordinator that was overseeing CCC. Kim is her name. she would always kind of bring out practice changes and would always type out like, this is what we did then, this is what we do now.
Right.
And one of the things that I remember, because when the worst thing that can happen to you, Drew, is like, you have a routine, you have a way of doing things, and imagine you've been doing this thing a certain way forever.
Right.
For as long as you've been doing it this way. And guess what? It's been working great for you. And then someone comes along and says, don't do it like that anymore. It's better to do it like this.
Right.
And then you're thinking, what's the point if the end goal is the same?
Fair enough.
Very fair.
Yes.
Right? And so when Kim came to the floor, because I was like, I was taught in school, I was taught in everywhere that I've worked, you can use a suction catheter 3 times. 1, still need to use it. 2, still need it.
3,
done.
then dispose it off. Right.
She was like, yeah, so now we're only supposed to use 1 per suction. And internally, I was just like, the supplies that we're going to waste. Oh my gosh.
Right.
Like one patient on our floor in particular uses like 15 of them in a 24-hour period, which is like a third of our entire unit stock in a day. Like, and that's just for him. And I'm just like, oh yeah, thinking in my head, yeah, all right, yeah, I'll definitely do that, Kim, sure. But again, I mean, and I'm speaking for like, old practice, new practice. It's like, but sometimes changing your practice is like grinding your own gears.
Fair enough. And
where you do have to be flexible and change your practice to make sure that the end goal is maintaining the patient's safety.
Absolutely.
When you discard one and done and you crack open a new one, you are effectively eliminating the risk of reintroducing any outside flora into the patient's open airway, which is the idea of it. When you have it, you pull it out, you're waiting. Sometimes that catheter can the tip of it can touch something else, or it can whip around in the air. And, when you're waiting for something to dry, you don't take a fan and fan it, right?
Right.
What do you think is going to happen when you have this suction catheter that's just waving around in the air? It's the same thing, right? So like if I can understand why they changed it, but again, we had a education coordinator that was pretty proactive in sharing best practices, and we happen to have a culture on CCC where we know that things change and practice needs to be changed, and when practices change, you need to incorporate that into your care so we can continue to be up to date with the best practices. And that was just one thing that I was been meaning 2 days ago or yesterday or Monday, I think, when you guys were on when Katie was on the floor. No, it wasn't Katie, it was Megan, your other groups. Clinician show. She's like, yeah, we just had a question about the suction thing. And I was like, yeah, I'm going to print it off. I'm going to print off the thing where it says, because I never fact checked her. I just took her word. And she had the printout, and I read the printout, but I never kept the printout. I'm like, okay, I don't need this. I'll just toss it, and I'll just write it up on the board. And now it's bread and butter.
Right.
But I remembered it because it was such like a nail on a chalkboard in my brain that like, oh my God, we got it one and done. Ugh. And but yeah, one and done. And if you go other places, there'll be still nurses that will do 3. Are they wrong? That's the gray area.
Oh, I see. Okay.
If you know best practice, you know what is best practice. Best practice is best practice. There's second best practice too.
Which is a humble way to say it.
Yeah, which is you go in 3.
Yeah.
Who wants to settle for second best? Not
Fair
me.
enough.
Yeah. But it could also just be like an ignorance thing. They might just not know.
Right.
Which is most likely the case everywhere. Because there's a lot of staff that still, not my unit, but there's staff on other units that still don't know that. And that's okay. It's not like their fault. It's a new practice from last year. It's not even a year old.
Oh, okay.
Yeah, it's brand new. It's brand new.
Okay, that makes sense.
Yeah.
Right.
So I remember yesterday your group came up.
Yes, we were there.
Katie pulled me aside and was just like, asked me a question that one of your classmates brought up. Was like, she was really concerned because she saw it and she was kind of having a meltdown inside. Oh. And I'm like, yeah, like I totally understand. Like I'll talk to the nurse and educate her, which I didn't get around to doing because busy. But
no, thank you so much. And then the other thing is, I was thinking we could talk a bit about PICC lines.
Yeah.
So, I think if I say what's the best practice for PICC line, that would be like a very long list of.
The CVAD guidelines in Quinny Health is many pages long. We're talking like 30, 40 pages long. I could not cite the whole thing, but I know enough of sterile technique and sterile practice and I've worked a lot with central lines. That was like most of my nursing career is working with central lines. So it's very second nature to me on how to care for it. But yeah, the best practice things too, and again,
So do we change, the best practice is to change the dressing every week, right? Once every week?
Uh-huh.
And then...
Or as needed.
Okay, or as needed. Mm-hmm. That's true.
So if you see a dressing that's soiled and you're like, oh, I don't need to change that. It's been changed 3 days ago, but it's obviously soiled. And you're like, I don't need to change that for 4 more days. According to what the best practice is, change once a week.
Right. Okay.
You change it because it's also as needed.
Absolutely.
Like you're a nurse.
Yes.
You have assessment skills.
Right.
You have to assess these needs continuously.
Right.
Is this PICC line still safe to use? Oh, that PICC line migrated out a little bit. What do we do for that?
Right.
Well, we need to notify the provider. We need to ask the provider if we can troubleshoot it. We got approval. And this is like yours and our experience that you and I had.
Yeah, absolutely.
And,
that's very true.
Like we need to see if it still flushes and draws. We got an X-ray, and guess where the tip was?
Was it intact?
It was intact.
Wow.
But it wasn't where it should have been. So the tip placement when patients are getting central lines, like a peripherally inserted central line catheter, catheter, PICC line for short, it terminates in your superior vena cava, your SVC.
Right.
And it terminates about 2 to 3 centimeters right above your atrium. Hers got pulled out about 5 centimeters on her arm, but it was in her subclavian.
Wow.
It was up here.
Wow.
And
that is okay?
It was deemed okay by the provider.
Oh, perfect. Okay.
Yeah.
Wow.
So, a lot of people would just be like, no, we're going to pull that and get it replaced.
Right.
But it was anchored fine, and subclavian lines are a thing. And, our MP consulted somebody to take a peek at it for an opinion, and it was okay to use. So,
I'm just going to say that those who do not know what we're talking about is that we're talking about a patient that is it okay to say we had?
Yeah.
And then that's something that happened, and it was perfectly fine. So
perfectly fine. Yeah. But we had to assess it.
Yes.
Right? Like it's one thing to see it, and I think that's the difference between like being an RN and an RPN. And we talk a lot about that, and we talk a lot about that in school too, because I'm the only RN on CCC.
Oh wow.
We only have RPNs on CCC. Our RPNs on CCC, I like to brag about them, are excellent. We have some of the strongest RPNs, in my opinion, that I've ever worked with.
That's amazing.
I want all of them to be RNs. Like I want them all. They all would be so good at it. But they're quite content with where they're at.
Since you're talking about all the RPNs on the floor, I just want to say thank you to every RPN. I hope I can remember the names. I want to thank Cassandra, Sandra, Kirsten, the other Kirsten too. I know there are 2 Kirstens, and then Danielle. And I apologize if I forget any names, but I think these are the ones who I come in contact with whenever I'm on placement, and I just want to thank all of them. They're super nice, they're super friendly, they're super welcoming, and are always ready to teach. And I think that kind of comes from you too, because you're always full of energy, and that kind of energizes the whole floor. And then everyone's like willing to, like teach and just have a very nice vibe on the floor. So thank you to everyone. Thank you, Andrew.
Appreciate it. Yeah.
Yeah, no, seriously. And I'm sorry if I forgot any names. Yeah.
Yeah. Deanna, Elaine.
Oh, yes. Oh, yes. I think I've met them too. And then I met, I think today
We have a few new hires too. Albin, he's a new hire.
I've met Albin. I have met Albin. I have also met Aliyah, if that's her name.
Yeah, she's brand new on her floor.
She's
there today.
She taught me the IV today.
Yeah. Oh,
so
cool.
That was really nice.
Yeah.
I was observing on one of the patients.
Yeah.
And huge shout out to her as well. And we were also learning from Ainsley. Mm-hmm. So that was really nice.
She's a good one. She's not from our unit.
I think she's in the transition pool.
Yeah, she is in transition pool.
Yes.
Yeah, she's nice to have on the floor too.
But yes, if this podcast reaches out to all of these guys, thank you so much.
Yeah.
Thank you, Henry, once again. Can't thank you enough, I guess.
I'm just a guy, Dhruv. I'm just a guy.
And thanks to my clinical coordinator too, Katie. Thank you, Katie. She's amazing. She's amazing.
She's a sweetheart.
Yeah. Yes, and then I actually did get a chance to do wound care today. Is there if I was to say what's the best practice for wound care, is that the appropriate question? Because I guess it's not, because there's different levels of wound.
That's a big can of worms.
I think you're right.
Yeah.
Yes.
The wound care. First of all, how did you think it went?
Oh, I think it went. I hope it went good, but I personally feel it was amazing. The experience was amazing.
What did you have to do?
Oh, okay. All right, I'm on spot here. So first we peeled off the dressing that was there, and we assessed the wound.
What did it look like? Was it gross?
It was.
Yeah.
Not too gross, but it was a bit gross, and we could see it was bleeding a bit. We could not figure out why it was bleeding, the exact cause, but it was bleeding, so we did note that down. And I remember the dimensions of the wound perfectly, because that's what I did just before getting here. It was
memory recency.
Yes, it was 2.5 centimeters long and 1.5 centimeters wide.
Perfect.
And
documented too.
Oh yes. And then while I was removing the dressing, I was washing it with saline. And then after we did that, my vocab for those things is really poor at the moment, but we applied.
There's like a million types of dressings.
Yes, it was like a net. Oh my God, I should know this, but anyways, it's okay. It was
all right.
It was a very thin net. The nurse that was helping me, I won't take her name. She helped me cut the dressing, and then I placed it on the wound. Before I placed it on the wound, we used the swab, I guess is the right name, to clean the wound. And after that was done, that's when I applied that dressing. And then on top of that, it was, I think it's the Aquagel. Is that what you call it? Aquacel.
Yeah.
Yes. Then I applied the Aquacel. And then, I don't remember if there was one more sheet of covering on it, but then after that, it was covered with the main dressing. And there we go.
How did that make you feel?
Amazing. I always love the part when I have to wear the sterile gloves on. I just
it's
love
very
that.
Satisfying. It's very
I don't
demure.
know. Yes.
Snap. Yeah.
Yes. It just makes me feel very good, I would say.
The wound care is very fascinating. I'm glad you. So let's talk about experiences as a nursing student.
Sure.
And I want to just kind of encourage all of your classmates and all of the students at Loyalist. Everyone's experience when they're going through a nursing program is very different from anybody else in the program.
For sure.
You know, like I happen to land the public health, and I happen to have 300, IM injections under my belt. I had classmates that never got to do one single IM injection the whole time.
This was going to be my question. Like, did each one of you get a chance to do that, or?
Nope. No, the public health rotation was for 4 nursing students in the program. Yeah.
Oh, I see.
So
okay.
It was limited. So not everyone got to experience that.
I mean, I would love to have that kind of experience.
You know what I never did in nursing school?
What's that?
I never placed an indwelling Foley catheter.
Oh, okay.
Never did that. I had classmates that did tons of them. Not me. I had to learn that on the job.
I see.
Which was something that I had to learn. Like placing IVs. I never had a chance. I had like 2 opportunities in in my consolidation to place an IV, and I flubbed both of them, and that was it. Like for skills, I am expert. Everything else, never touched it outside of lab, and that was my experience,
Right.
But that's just it. Like you can, even though you didn't get to experience it in nursing school, it's not going to make your experience on the job any different.
I was going to ask you something related to that, because as students, we are not allowed to access central lines.
That's right.
And should we be allowed? I don't know if that's the right thing to ask, but to gain more experience. And I think as a student, you're always very curious to do those things. But I understand from the bigger picture that, hey, okay, the patient's life is at risk here.
Yeah.
So
that's a great question to ask the College of Nurses of Ontario.
Let's
get
fair.
them on the line. Can you get them on the line here for you? Yeah, sweet, excellent. We'll give them a call.
That's actually true. Yes.
There is rules in regards to because you're not registered yet.
No.
And you're not accountable to your profession yet.
Right.
The hospital as well has insurance that is separate from the insurance that you have right now as a Loyalist College student.
Oh, I see.
That's one part of it. There's another part where there's actual regulations as a registered nurse and what things you aren't and are allowed to do. Like when you're digitally disimpacting someone's rectum because they're so FOS, that's full of shit.
Right. That's a good acronym, though.
Yeah. Your patient's FOS positive. That's a good way to say that.
Yeah. When they need a bedpan.
There's actually laws and rules on how far you can insert past the surface of the skin.
Oh, I see.
For anywhere. Could be oral, could be rectal, could be nasal, could be anywhere. It's
right.
the same thing. And there's rules and laws for everything, even with accessing or being able to use a device to pierce through skin. That's a protected skill under registration. So there's things like that are protected skills with which comes with nurse registration.
Right.
So those things will never be granted to students.
Fair enough.
Even if the hospital's like, yes, you absolutely can do that. But hospitals can't say that because as a registered nurse, only registered nurses can do certain things.
And then they don't even cover us for that, right? So
that's right.
That's, yeah.
Yeah.
Makes sense.
Yeah. We have that printout. Excuse me. We have that printout too on the unit that kind of explains like the nurse.
Oh, yes.
Extern.
I think it's the purple and the red colored sheet.
Oh, that's for IVs. There's another
okay.
one to the right of that where it has like 4 different columns. Has like what PSWs can do.
Oh, okay.
What clinical externs can do. What consolidating nurses can do. Which every student in the nursing program falls as a consolidating nurse. Even if they're in their second year, if they haven't learned the skill, they're obviously not going to be doing that skill.
Right.
But they are, once they've learned the skill, whatever's in that consolidating nurse section, they'll be able to do all of that. If anyone's listening, interested to see in that, it's just on our floor.
Perfect.
Just to flag it down. And then you have like all green for like once you're fully registered, then you can do all of these things. It's kind of like the skills that nursing can do it in clinical
right.
health. Yeah.
Oh, perfect. And so I believe so when you finish your schooling, we have to pass the NCLEX exam.
Yes.
What advice would you give? Like, how should a student prepare for that exam and pass it with flying colors?
Don't take it lightly.
Perfect.
I failed the NCLEX.
Oh, you did? It doesn't look like.
Yeah, I appreciate that.
I would have never thought that.
Yeah, no, I was the first cohort to write the NCLEX when it was introduced in Canada.
Oh, okay.
And the first time writers writing it for the first time nationally was a 30% success rate, 30% pass rate.
Just 30%?
30%. That was national for the NCLEX. The pass rate for second-time writers was 15%.
Oh my God. Okay, I was thinking that the number's going to go up.
It was worse.
Wow.
Crazy, right? NCLEX
15%.
at that time was the world's hardest registration exam if you're going by statistics of pass and fail. Like if you look at the physiotherapy registry examination, their pass rate's like 98%. Same with other registered professionals. Very, very high pass rate. In the States, the same year in the United States, that the year that we wrote the NCLEX in Canada, America's national average was a 81% pass rate for first-time writers.
Wow.
Which is grossly low.
Oh.
It's very low.
You say that's low.
Pass rate, yeah.
Oh, okay.
If I'm comparing it relatively to other professions.
Right.
So if we had you and 4 of your friends, one of them would fail.
Oh, that's sad.
It's crazy. It's changed now, and I'll shed light on that. It's for the better, actually.
Thank you.
You're welcome, everyone. Because when I wrote it, it was so grueling. It was 265 questions over 4 hours.
Oh, okay.
And
it's a 4-hour exam.
yeah, and there's how the NCLEX exam works is it's a SMART exam. So when it confidently feels that you are passing, it'll just shut off the exam and be like, you're good, you're passed. It tests you in every area that nursing needs competencies in: oncology, pediatrics, medicine, surgery, assessment, whatever, all those kinds of things. And it will keep giving you questions that you're bad at.
Wow.
So
that makes me feel better.
it was terrible. And there's the outcomes. You either pass, overwhelmingly pass, I'll say, where the test shuts off, you pass. You overwhelmingly fail, the test shuts off, you fail,
Okay.
which happened to me.
So does it tell you right away?
Nope.
Oh, okay.
You got to wait, which is
shit.
the worst.
Okay.
Yeah, there's a trick that you can do, which I'm not going to share on the internet over the waves, but there's a very well-known online trick to know whether you passed or failed the day of. Easy to find. Just Google it. Can I say that? Google it? Yeah. Trust the internet. Just kidding. And then there's 2 other options. You either answered every question on the test. So at question number 265, if that question was in the pass range, whether you get that answer right or wrong, you pass.
Oh, okay.
If that question falls in the fail range, even if you get that answer right or wrong, you fail. And it's just based on that last question. The worst outcome that you can have is if you time out in the exam.
Okay.
Because if you run out of time, it takes the last, I don't know what it is now, but when I wrote it, it was the last 70 questions that you wrote. And every one of those questions has to be in the pass range. If any time it dipped below the pass range, it's a fail.
Oh my God. Okay.
Yeah.
That's like fighting for life there.
Yeah, and I timed out. So I was like, I just wrote it a second time, and I'm going to fail. I already called in the towel. I didn't even want to do the trick, the NCLEX trick. It's what it's called on the internet.
I see.
To see if I passed, because I was like freaking out. I ended up passing, which was crazy, because I'm like, woo.
Well, congratulations.
Yeah, thank you. Yeah, I'm a nurse now. Yes, I know. Look at me, so demure.
Too late to congratulate now.
Yeah.
So what was the approach? Yes.
Okay.
Like how was the approach different when you failed and then obviously when you passed?
I took it seriously. Yeah.
Okay.
It's not a joke exam. Like you can't just I was a natural test taker through my whole life.
Wow.
I always make fun of myself for being kind of dumb and not smart, but reality is
you're very smart.
I appreciate that, but I take tests very well, and my memory recall is sharp.
Wow.
So I was always good at writing tests. But so going into the NCLEX, I'm like, this is just a regular old exam. I just got to read this one book, like the Saunders Comprehensive Nursing, whatever, and that's all I got to do. Read through that, write the exam, I'm good. Ace in the hole. I'm smart. And Well, it shut off at 75 questions, which is the bare minimum you can write before the test decides.
Oh my God.
So, and then I failed, and I was like, sweet. I thought it was such an easy exam. I was so confident that I passed, and then I didn't. So what I did the second time around, and this is what I recommend every nursing student to do.
I hope everyone's taking notes if they're students.
Yeah, it's
because I'm taking two.
Yeah, UWorld.
Oh, UWorld. Okay.
UWorld.
Yes.
I've had classmates that only did UWorld, and what they'd do a question, right or wrong. They'd write down the rationale on a cue card, put it away. Do a question, right or wrong. They'd read the answer, put it on a cue card, put it away.
So does it tell you the answer? Oh, well, obviously it tells you the answer when you write. But does the rationale is still given to you?
The rationale's still given to you.
Oh, perfect.
So you write the rationale on a cue card, and what do you do with those cue cards? You review them
over and over again.
Over and over again. And then the next day, put that set aside. Make a new set of cue cards. Do the questions. Put them aside. Do it over here. Put them aside. Do them over here.
Wow.
And by the end, you got a big fat stack of stuff that you're reviewing every day while you're still doing these questions. UWorld's got like 3,000, 5,000. I don't know how many questions they have in their question bank anymore. But like when I was doing, I never did UWorld. Probably why I struggled. When there was like only 1,200 questions in the bank in UWorld when it first came out in the area when I was doing it, all good. But now there's like thousands of questions in there, and I've known people just to do that and they pass.
So the way you describe it, I'm guessing that's the best approach, because I mean, even if students don't get time to go through each and every book that they had during their 4 years, I think UWorld is that kind of summarized learning program that you can kind of go through everything that you did, or maybe not. I could be wrong.
It does give rationale, but the nurse has to understand the rationale, and that's what the nursing program's for.
Yes.
Because I could say to you, COVID invades the ACE inhibitor, the ACE pathway.
But if I do not know the pathway,
how do you assess?
Yes.
Like if you don't know the pathway,
right?
Or like, how does pain work in the body?
Right.
Why is there inflammation in my knee?
Right.
What causes inflammation and why does it hurt? What is that process?
Right.
And then like sometimes the rationale would be like really in depth, but if you're like, go through nursing school and you're totally fine, you can work out exactly what they're trying to say with the rationale.
Right.
So like, go ahead.
So how long did you have from the time which you unfortunately failed the first
45
one?
days.
Oh wait, okay. So you took the test in 45 days.
That's the earliest you can take it.
And that's what you did.
That's what I did.
Oh wow.
Yeah.
So what did you do in these 45 days?
So the first time I only studied for 2 weeks.
Okay.
And to me was the longest I've ever studied for anything ever in my life. It was 2 weeks.
All right.
And I failed miserably. I'm like, how hard is this test? And then I bought the Saunders comprehensive guide. That's what I used.
Sandra's comprehensive guide.
Yeah, Saunders comprehensive NCLEX guide.
Right.
Excellent. I still use it.
I should write that
for
down.
My
actually.
nursing practice.
Just for myself.
Like sometimes when I'm like, I had this thing come up and I don't know how to assess for it, and it's always nursing specific. It's an incredible resource. Like when I was done nursing, I always held on to some of my books. After nursing school, the only books I kept after nursing school was my Saunders comprehensive guide and my Jarvis.
Jarvis physical and health assessment
right. book. Those two books.
I have that in my bag right now.
Oh my God, bread and butter for nursing. Everything else is kind of like the introductory, the fundamentals of nursing is also a good book, but it's also like 1,400 pages.
Oh, wow.
The Saunders book compresses that entire book into like 300 pages.
Wow.
So it's good. It's a good resource. I liked to study like that. I don't like doing questions over and over and over again. I like reading. So I did just the Saunders comprehensive guide and I passed. Some people do it both. Some people, there's no wrong way to go about it. It all depends on how you do it. I've heard people, the most success is through like online question banks. There's another one like UWorld that other people used. It doesn't matter which one. They all cost money. It doesn't matter which one you use.
Right.
Just crush out the questions and understand the rationale that they're saying.
So just to recap it, during those 45 days, your go-to guide was, one of the guides I would say was Saunders Comprehensive Guide.
Mm-hmm.
and Jarvis, I'm guessing.
Yep.
And then you did some questions.
I never did questions.
Oh, okay.
Never.
Oh,
no,
okay.
no.
Oh.
And I'm recommending UWorld because my life probably would have been a lot easier if I did UWorld.
All right. You were listed there too.
Yeah, and I hear
Perfect.
just amazing things. Like, I'm not sponsored by UWorld or anything, anyone, but shout out to UWorld.
They should probably sponsor this.
I know.
guess.
That's right. Give me money.
Yeah.
I'm looking for a job. I'm not looking for a job. I love my job.
no,
I love my job.
Since you said that, maybe and towards the end now we can talk about the financial opportunities after nursing.
Yeah.
How is that? Let's talk about that. I mean,
It's yeah. So getting a job is easy as a nurse.
right.
You'll never be without work. It's arguably one of the most secure professions you can go into
Right.
today. Secure as in you can find a job and you can work that job for your entire life.
Perfect.
And you'll never be at risk of losing your job.
Right.
Well, I won't say never. Sometimes, like, they had to do a layoff in the 90s once upon a time, but that was before.
Long time ago.
Long time ago.
Yes.
Yeah. But
And then what are the opportunities as an RN? I know a lot of people who do want to work in hospital settings. There are some people who do not want to work in
Yeah.
hospital settings.
absolutely.
So I guess the pathway is kind of clear for the ones who do want to work in the hospitals. But what about the ones who do not want to work in the hospitals?
So that's a very good question. There's as a nurse, we're very diverse in the areas that we can work in. We can work in consulting. We can work in politics, policy, government.
Oh, okay.
We can work in data analytics, research. We can work in primary care. We can do an office. We can do bedside, obviously. That's the most obvious thing.
Yes.
There are so many opportunities. One, I'll kind of tuck on my one coworker, one of my clerks, Stephanie. She would love to be like a nurse data analyst.
Okay.
She shared that with me. She's like, yeah. She's like, but I would never go through nursing school, because she's like, I would love to have this job, but I don't want to go through nursing school because she hates patient care. Yeah.
Okay.
And I'm just like, well, it's a means to an end. Like, if you knew if you
Right.
had to slog through that, in your words, like, to get to the job that you want to do,
Right.
wouldn't it be worth it? She's like, no. But that's her thing. But,
Right.
yeah, you can graduate nursing school and never touch a patient for the rest of your nursing career.
Oh,
There's jobs out there that are like that.
and they're well paid too, I'm
Well
guessing.
paid, yeah. Well, it depends. Like, I mean, there's union jobs, there's non-union jobs. Relatively, nurses make the same amount of money. My job is publicly disclosed just because I work in Ontario's largest nursing union, and you have years you worked in and the role that you have. Like, anyone can look up anyone's salary. Oh, how long have you been working? About 5 years. Are you patient care lead? Oh, okay. I know exactly how much money you're making. Like, it's
okay.
all public information.
Oh,
Like,
okay.
nothing's a surprise.
I see.
And that's with every public paid thing. That's how the public holds the government accountable. So people aren't making too much money from the public dollar, because tax on it.
Right.
Which is a whole other podcast. But anyways,
Fair enough.
No, it's a very, now is kind of a weird time. How old are you? You young?
Yes, I'm 25.
25?
Yes.
So you're just kind of starting, like, you'll be graduating nursing school when relatively wages are low and cost of living is high.
Right.
And it's all about, like, your expendable income.
Absolutely.
You'll have more expendable income living in smaller areas. A nurse working in Bancroft as a patient care lead that's been 8 years in the seniority in the pay scale is making the exact same amount of money as a patient care lead in an oncology unit at Princess Margaret Hospital in Toronto. Who's making more money? The one in Bancroft.
That's true.
So it's like they're making the same amount of money. On paper, yeah, it looks good. Like, I'm not going to say, like, that nursing doesn't pay well. It does pay well.
Right.
Relative to the global climate of what's going on with mortgage rates. And
Yes.
I'm not a financial expert by any means. What I can touch on is that things are expensive, and nursing can afford you a lifestyle that can be comfortable.
Fair enough.
Which, unfortunately, a lot of people get into nursing because of that.
Okay.
Which, if you're going into nursing for the pay, find a different career, please, for the sake of your patients.
Right.
For the sake of your families and for your own mental health, don't go into nursing if you're only in for it for the money. It only pays okay. It's not worth it if you don't love it. If you don't love what you do, if you don't like making people feel good, if you don't love taking care of people when they're at their lowest of the low, doing special things for people, making them feel good, makes me feel good. That's why I'm still in it. But yeah, don't waste your time if your heart's not in the care aspect of nursing.
I think that's a very good piece of advice. Also, a lot of students, I know a lot of parents who kind of sometimes ask me, because since they know that I'm into nursing, so they're like, oh, how's nursing? And I think this is the right time and place for someone like you to answer that. If someone's looking to go into this field, what piece of advice would you give? Is it hard? I think yes. I mean, obviously it's hard, but what piece of advice would you give to someone who is thinking about being a nurse?
Sitting on the fence about it?
Yes.
Try it. That would, honestly, I think there's the stereotypical cookie cutter that everyone imagines the personality of what a nurse should be like.
Right.
A nurse should be feminine. That's like a stereotype that's been for the ages. What does feminine mean? It means compassionate. These are all gender normatives and gender specific things that have been ingrained in time immemorial, even still to this day. Like the male to female ratio of workers in the nursing profession has been the same since like the 80s. Or since the early 90s. It's like 15% men, 85% women. And it hasn't changed. It still is that way. So when they think of a nurse, they don't automatically think of a male. They think it's a compassionate, kind, empathetic, non-confrontational kind of personality.
Yes.
That's the stereotype of what a nurse is.
Yep.
Reality is anybody with any personality can find a place in nursing where they can excel at.
Wow.
Like, there's, some people, I have some classmates, and I won't name names, but going through school, I'm like, how are you going to ever do bedside? Like, I don't see it. But, excuse me, they ended up doing something that wasn't bedside. They started their own foot care business or something like that.
Oh, okay.
They went into nurse aesthetics.
I see.
And, excuse me, and they ended up being very, very successful. They never ended up touching a patient outside of nursing school.
Oh.
Instead, they're just like, they're just doing injections in people's lips and forehead and eyebrows.
Oh, okay. I see.
And they're happy doing that.
Right.
And they're very successful, and they love that. I wouldn't necessarily, I mean, I'd probably say there's a spot for anyone in nursing, in any area of work. If you don't like talking to people, you can go to the OR suite. You never talk to people in the OR suite.
Right.
You just talk with like doctors sometimes, but not really.
Okay.
If you kind of like your ducks in a row, you don't like talking to people, you're more introverted, OR might be a great spot for you. If you like flying by the seat of your pants, you're very outgoing, and you want to do something crazy every single day, you might not be the most organized person in the world, but you can multitask kind of. Try emergency department.
Right.
You might thrive in chaos. And
Fair
you are more of like a person that really likes your ducks in a row, but you also like the care aspect, you can try ICU. If you want to be like a jack of all trades and do it all, do medicine. If you want to do, if you're like every personality has it. Like, I think if anyone is sitting on the fence about it, it's never like I convince them by the job security, and don't think that you won't have the personality to be a good nurse, because being a good nurse comes from the heart. It's like the drive to continuously be successful as a nurse always comes from the pit of your heart. That's, I want to do what's best for my patients.
Right.
And if you're going to do that, then everything else will kind of fall in line. Of course, I want to know what best practices are. Of course, I want to read my patient's history and learn the things. Of course, if I'm giving out a medication and there's a medication in this pill, in this MAR medication administration record, that I don't know, of course I'm going to look it up, because I don't want to do anything to my patients that I don't know what's going on. I want to know everything. I think that's why I liked ICU so much, because I like knowing everything about my patient. But I also liked talking to patients, so I couldn't really find a spot that kind of satisfied both worlds. Maybe like a dialysis clinic, that'd be kind of fun. But anyways, do it. Just try it.
Absolutely.
Yeah.
Wow. And before we end this podcast, do you want to share your first experience and then your best experience? I'm sure you've had, because being a nurse, there's like so many experiences, even like every day.
Yeah.
But let's start with let's do one first, and then let's end it with one of the best or memorable experiences you had.
This story is for Julie Abelard, because I always share this with her students, and I haven't had a chance to touch base with her class.
Is she at Loyalist?
She's an educator at Loyalist. Yeah.
Oh, I think I know her.
Abelard.
Julie, yes.
Yeah.
She's she teaches pathology.
That's right.
Yes. Oh,
That's
wow.
right. The best pathology teacher in the world.
Oh, I'm going to make sure she hears this.
Yeah, she better. She knows it too. At least I tell her every day, every time I see her.
I love her energy too.
Oh, she's fantastic.
Yes.
Yeah, she's a great asset to the nursing program, in my opinion. So I was placed at Napanee Hospital, and we just learned about infectious diseases in lab.
Right.
We learned about VRE, MRSA, C. diff, and like all the precautions and what it looks like if it gets really, really bad. And we were also learning about neurological progressive diseases such as like Parkinson's, Alzheimer's, all that kind of stuff. So I was paired up with my classmate Carly, and Carly and I were paired up. We had one patient between the two of us, and we had to go in, and this was our first patient ever, and we had to go in there and do an assessment on our patient and introduce ourselves. And I was freaking out because the patient had MS, multiple sclerosis, and she was only in her 40s, and she was already like at end stage MS, which is very sad. So my heart was like being real sad, right? And I go in there, and Carly's outside, because we decided to introduce ourselves separately to keep the peace going and be really gentle. And she's like, I was like, hey, my name's Andrew. I'm going to be your nursing student for the day, and what we're going to be doing is we're going to be coming in sometime soon to do a whole head to toe on you, and if it's okay with you, Carly and I are going to get you washed up and get you ready for the day. And she looked at me with the biggest concern on her face, and I'm like, oh man, is my first patient going to fire me because I'm a male nurse, which happens. And she mumbled something, and I couldn't understand. I'm like, I'm sorry, I did not hear what you say. I apologize. And I get closer, and she's like, mumbled something. And I'm just like, I am so sorry. Like, I cannot understand a thing you're saying. And I'm talking to her like this. I'm like, I cannot understand a thing you're saying right now.
Right.
And I'm doing my hardest. Like, I'm doing my best. I was like, can you try one more time? And she has this shit-eating grin on her face. And I get up to my computer, and she's just like, wash my beaver. And I'm just like, oh my God. I was like, ma'am, when we get you washed up, we're going to get you cleaned up. You don't have to worry about it. You don't have to worry about it. And she was dying laughing. She's just seeing me sweat. And I was like, if this is the kind of person that you are, I think you and I are going to get along just fine, I think. And then she broke the ice. And I learned a very valuable lesson. When people have sad experiences, the worst thing that you can be as a nurse is be a sad nurse.
I think that's very true.
You don't want to be the sad nurse working on a patient that has a sad circumstance.
Yes.
That just exacerbates their sadness. And then they're going to be like, I don't like this nurse because now I'm sad.
Yeah.
You want to be the hype nurse, counteract, like make them breathe some life into these people. You know what I mean? So that was
true.
my first experience ever at bedside. It was shocking. And then my craziest experience as a nurse was probably this. I remember it like it was yesterday. It was the second last day I was in the COVID ICU.
Oh. Okay.
And on the floor, we had 3 patients on the floor under the age of 27.
This is in Arizona.
This is in Arizona.
Right.
And they were all on 2 of them were on ECMO.
Right.
And one of them was going to get cannulated, which means that they're going to do this thing where they paralyze the patient.
Oh.
They're going to shove that thing into her heart, and they're going to start putting her to sleep and doing this all whatever. She elected. Oh my gosh, sorry.
Oh, go ahead. Feel free.
She elected to do what they call an awake cannulation, where she wanted to be awake while they put this thing through her heart.
Really?
And to this day, I believe she was the only one that I've known during the whole pandemic to ever have an awake cannulation happen. This girl was so brave. She was pregnant. She was 28, 29 weeks pregnant. And
she was pregnant.
Yeah. Oh, yeah. Yeah. Again, and she had COVID. So her lungs were failing. And we were like, your lungs are failing too quickly, and we need to start oxygenating you to keep you alive. And so we're going through, I'm not at bedside at this time. It's the doctors that are coordinating. What I'm coordinating is I have to call the neonatal ICU to get their giraffe. The giraffe is the baby incubator. I was like, get your pediatric ICU team, your NICU team down here with the giraffe in case the cannulation goes wrong and we have to emergently C-section the baby out of the mom. These are real conversations. I had to call the cardiothoracic surgeon to coordinate the time with that. I also had to call and coordinate with the respiratory therapy team and the pulmonologist to come to bedside with a ventilator to intubate the patient in case she crashes and burns. I had to get the code cart beside the room and designate some of our nurses to be on the code cart. In case her heart stops during this, we need to all jump in there and save the mom's life and save the baby's life as best we can.
Wow. I'm just trying to imagine the pressure and everything at that time.
It was super high pressure. I had to tell, because this was the craziest thing that's ever happened on this floor. And naturally, when crazy things happen, everybody wants to look.
Yes.
Everyone wants to look. And so I had to play bad cop and be like, if you're not a part of this, this is a really big operation. If you are not a part of this, I need you to leave this unit. And so we only had the people that were directly involved with this. So there's always 2 parts to a cannulation. There's first getting it into the heart, and then there's the second turning on the machine.
Oh, okay.
Because when you get the cannula through the heart, it occludes blood flow, which means your oxygenation is going to go from, hers was like 88, 85%, like on 100% non-rebreather already. And as soon as what happens with every cannulation, you get that thing through the heart, their oxygen will go 85, 75, 65, 55, 45. Like, it drops so fast. But as soon as you turn that machine on, it goes 100%, like in seconds. It's insane. And what was insane was the girl was awake during the whole thing. Usually people are on breathing machines. They're paralyzed. They are like under, they're under heavy sedation.
Right.
And we just did local anesthetic for her. And we're like, okay, you ready? Family was outside the room. We had the radiologist, the portable CT scan in the room. We had the cardiothoracic surgeon in the room. We had the perfusionist in the room.
It's like a whole movie scene going on here.
There's a whole movie scene. And outside of the room was the code cart, was the intubation team, was the code team, was the neonatal ICU team. There's like 20 people just waiting for this to happen. I know it's 9 o'clock. And then we started. So I'm standing outside of the room watching this monitor. And whenever they're advancing this big fat garden hose of a cannula into your heart, your heart flips out. It freaks out. It tickles the SA node. I remember talking to some of your students about this, some of your classmates about this.
I think it was like a few weeks ago we were talking about SNO.
And it can make your heart go into an arrhythmia.
So that's the pacemaker of the heart, right?
Pretty much, yeah. And it can tickle that, and the heart's like, what the hell's going on? Doesn't like it. So that always happens. So when the heart starts freaking out like that, that's when you know you're getting close. When the patient is almost dying. With this and she's awake, okay? So she gets to that point, the heart's freaking out. Now everyone starts holding their breath. And we get it down there. And now her oxygen starts going lower and lower and lower. The patient, once again, is awake. And she is feeling all of this. She knows her heart's freaking out. She knows she's seconds away from death with like this thing fondling her heart. She knows she's minutes away from death from her oxygen going so low. And now it's in the right spot and her oxygen is 45%. And now we turn on the machine. And like, it was so quiet in the ICU, you could hear a pin drop.
Wow.
And right when that machine turned on, they're like, the machine's on. And you wait 5 seconds. 1, 2, 3, 4, 5. What's the oxygen doing? It's at 100%.
Wow.
It was like everybody that was waiting just started crying.
Wow.
Everyone was just like, I can't believe it. Everyone was like, we're so proud of the patient for like doing that.
Seriously, wow.
Everyone was just like a wreck. And of the 3 mothers that was on this ECMO device, she was the only one that survived. We had to C-section her to keep her baby alive.
And did the baby survive too?
The baby lived and the patient lived. The other 2, the mothers died and the babies lived.
Oh my God.
Yeah. So it's like super high stress.
That is such a beautiful
And that
story.
was my second last shift in the COVID ICU. Bye. Bye, Felicia.
Oh my God. Thank you so much for this podcast, Andrew. And there was so much, I would say, range of emotions that we went through listening to you too. And then especially the last experience that you just shared. Wow, it
was crazy.
Wow.
Yeah. Never want to do that again.
And the way you were describing it, I could feel standing in the room and with that pin drop silence in the room. And I think even when you were counting, the studio was so silent.
Yeah.
I could feel it.
It's very theatrical.
Yes.
Was that on purpose? It was on purpose. Totally
oh my God. That was amazing. Yeah. Thank you so much for this podcast, Andrew. And I'm very grateful for you to take time out for this. And I'm sure every nursing student who's listening to this feels the same. Thank you so much. Thank you for watching this podcast. Me personally, as a nursing student, I loved how Andrew described how I can prepare for my NCLEX exams and also the experiences that I am prepared for in this journey as a nurse and the challenges that I'm going to face. But after listening to Andrew, I think I am well prepared for all of that. And I do want to thank my classmates as well. Hannah, Azaria, Carrie, Fernan, Tara, Caitlin, Jess. If I missed anyone, I'm sorry. But you guys are amazing. And also shout out to SILS 4 unit, You guys are amazing. Thank you for making us feel so safe and welcoming all the time. And thank you for everything that you're teaching us. Thank you. Do not forget to leave a comment and subscribe the channel. Thanks.